Hello, everyone. Eileen O'Reilly here. I'm a medical oncologist from Memorial Sloan Kettering Cancer Center in New York. And the topic today is current and future role of biomarker-based decision-making in advanced pancreas cancer. And I do think we're entering an exciting era in pancreas cancer. And this kind of slide summarizes where we are, but also where we're hoping to go in this disease. So it's fair to say that for the majority of people, the mainstay of treatment in the advanced pancreas cancer space remains chemotherapy with either modified FOLFIRINOX with gemcitabine nab-paclitaxel, and with increasingly the consideration of NALIRIFOX. And this is a discussion in itself, but I'm going to focus more on the biomarker-based aspects. So we know already that there's about 6 to 8% of people with pancreas cancer who do not have a KRAS mutation. That subset is enriched in younger people. And in that context, we see a number of actionable findings, a number of FDA-approved disease-agnostic indications for biomarker-based therapy in this disease. And we'll pick out a couple of these as we go in the talk. And then an additional area that's very important in pancreas cancer is the homologous repair deficient group. We see about 5 to 8% of people who have either a germline or somatic BRCA1, BRCA2, or PALB2 mutation. And for those individuals, platinum-based therapies, PARP inhibitors, and increasingly the role of immunotherapy is a question on the table. And then I'll just going to spend in the talk a little bit of time highlighting KRAS mutated pancreas cancer. And this is hopefully where the future is headed in terms of new opportunities in this disease. And given that we see almost ubiquitous KRAS mutations in this disease, of which there's proof of principle already with KRAS G12C targeting, and for the more common allele variants that there's drugs in the clinic and many more to come. And then there's a number of other biomarker-based opportunities that are being evaluated in clinical trials that we'll highlight during the talk. So to introduce perhaps the most well-established area of biomarker-based therapy is DNA repair, and a case here to set the scene. This is a 52-year-old who had a history of back pain, family history of germline BRCA2 and prostate cancer in the family, no pancreas cancer in this family, and presented with pain, elevated tumor markers, and you can see here multiple metastases. I think the scan understates the degree of pain that this individual had. Went on to receive platinum-based therapy, had an excellent response, and in the context of confirmation of germline BRCA2, question of what is the best maintenance therapy? Should it be continuation of chemotherapy? Should it be dropping the oxaliplatin? Should it be switching to capecitabine, or utilization of a PARP inhibitor? We'll just also note that the somatic genomics were pretty classic for pancreas cancer, KRAS G12D, and a low tumor mutation burden. So we'll continue here and then we can circle back on this. So just a reminder regarding the germline alterations in this disease. About 10% of patients will have a germline predisposition to pancreas cancer. Again, mostly BRCA1, BRCA2, but also ATM. And for all patients now, for the last number of years, it's in all guidelines in North America, ASCO, NCCN, for germline testing for this disease. And the big implication from the therapeutic perspective is identification of homologous repair deficiency and the associated role of platinums and PARP inhibitor therapy. So this is one of the studies from a couple of years ago, sponsored by the NCI, looking at platinum plus or minus veliparib in a group of patients who had germline BRCA1 and BRCA2 or PALB2. And this was evaluating whether adding a PARP inhibitor concurrent to, not sequential here, concurrent to platinum therapy might be a way to proceed in the clinic. So there were a number of observations, and this study was multi-center, prospective, and randomized. Firstly, we saw a very high response rate for pancreas cancer in both treatment arms, 74% for the triplet and 65% for the doublet. And we saw also an encouraging overall survival. I think this does not do justice to, it was in parts of the world where additional therapies beyond recurrence were not fully, I think, there weren't full opportunities there. But what we saw was that giving a PARP inhibitor concurrent with chemotherapy led to a lot of myelosuppression, some dose delays, a lot of reductions, and wasn't a better strategy. And in the subset of patients who went on to receive sequential PARP inhibitor, we saw very similar results to what we saw in the POLO study. And this treatment supports the use of cisplatin and gemcitabine for patients with germline or somatic BRCA1 and BRCA2 or PALB2, and is an alternative to FOLFIRINOX. So just speaking to this concept of synthetic lethality and why platinum agents, DNA damaging agents, and PARP inhibitors work, they confer a selective advantage in the tumor, resulting in inefficient DNA repair and increased apoptosis and cell death, with a higher therapeutic index in the normal cells relative to the malignant cells. And the strategy on the bottom is sort of what happens here. And this is why PARP inhibitors, not only are they a maintenance treatment, they're an oncologic therapy that it can induce disease regression. So we look at this with regard to the POLO study, and this is a phase 3 practice endorsing study in pancreas cancer. It was a large trial, enrolled or screened rather 3,500 patients to identify 154 patients to be randomized following 4 months at least of platinum-based therapy with a known germline BRCA1 or BRCA2 mutation. Patients were randomized in a 3-to-2 fashion to olaparib versus placebo. And probably these days this wouldn't pass as a control arm of placebo, but it did then. And the primary endpoint of the study was progression-free survival. It was doubled in the olaparib arm relative to placebo. You'll see the longer-term survival, and this was from the time of enrollment, not from the time of diagnosis, was not statistically different, although numerically there were more patients alive who'd received the sequential PARP inhibitor arm relative to the sequential placebo-controlled arm. And this led to the FDA approval of olaparib in the maintenance setting for patients with germline BRCA1 or BRCA2 alteration. And just to note that to be able to differentiate a survival advantage, it would have taken a much larger sample size. So I think we can't draw the conclusion that it's not there, but that this was not powered for that. So this is a slightly different version of the patient, a separate patient rather, that presented to introduce this topic, just to show you how well these drugs can work in this setting. So this was a 66-year-old who had platinum-based therapy and went on to receive a PARP inhibitor. And you can see CA99 of 40,000, very sick at presentation, and pending duodenal obstruction, moderate volume of liver metastasis, but anorexia, fatigue, pain, weight loss, and hasn't met a CR, but this is now measured in almost 7 years and is ongoing. So just illustrating that there are probably, a group of patients that, may be cured of their disease with this strategy in metastatic pancreas cancer setting with a BRCA alteration. But we have this nice dilemma of what to do. And this is a discussion point that we have not infrequently in the clinic for these patients.
I'm curious if you have any thoughts about why we didn't see a greater impact, particularly when you compare it to, let's say, ovarian cancer, for example, where they had such a dramatic, kind of really the same strategy with a hazard rate like 0.3 or something. Any thoughts about why you don't see more of an impact here?
Yeah, I think everything is harder in pancreas cancer, right? There's increased levels of de novo resistance and increased levels of acquired resistance. And it's, possibly the tumor microenvironment, the immune environment of this disease is just distinct and not replicative of what's going on in breast cancer and in ovarian cancer. And I think your point is, very well taken. These drugs can work, but they don't work as well or as durably for as many patients in pancreas cancer relative to those other malignancies. And a big focus now is, how can we turn this acquired resistance or the de novo resistance into platinum-sensitive disease and PARP inhibitor-sensitive therapy? And there's, work focused on trying to understand these areas.
Another question before you start moving on is, I'm curious how you have been managing patients, and have a patient with a BRCA germline mutation like this patient. Are you usually using a PARP inhibitor as maintenance therapy? Are you using the POLO strategy, or you use it selectively, or you don't use it?
Yeah, definitely do use it. It's a discussion, I think, on an individual person context basis. So for an individual who has, bulky symptomatic disease, who's responding, will usually continue to maximal response. And one of the points, though, we know is that PARP inhibitors don't work well when we're seeing resistance to platinum therapy, if they work at all. There's some anecdotal reports in that context. So I do think there's a sweet spot, somewhere between 4 and 8 months for most patients, if one is going to avail of the opportunity to switch off cytotoxic therapy and use an oral maintenance strategy after their disease is, maximally controlled. I think is a good time to introduce it. And most patients are keen for this. It's time away from infusions, time away from the clinic, more flexibility in their lifestyle. And we do see, for some of these patients, continued responses. But I think it's also fair to say we do see some quick progressions as well. And that's a group where there's, a focus on and trying to understand, to your question a moment ago, why and how we can stop that and prevent that. And that speaks to some of the trials that are underway in this space.
So another thought had is, and I hadn't thought about before, is in the POLO study, what fraction of the patients got a cis-based platinum regimen?
It's a small percentage. Most patients got FOLFIRINOX. About maybe I think it's 5 or 7% got cisplatin based, and the data was just emerging as the POLO trial was finishing, so it wasn't really, I think, fully recognized that that might be an option. And I think it's fair to say most patients, if we don't know their germline status when we're starting treatment and they're otherwise healthy, we're going to recommend FOLFIRINOX and not cisplatin and gemcitabine. That would only really apply if we have a de novo awareness of their germline status for that to be an appropriate consideration. And I think there's also the question in many people's minds, is the triplet better than the doublet in this setting in terms of response and durability? What we glean from the POLO study is we didn't see a difference between cis platinum-based therapy versus FOLFIRINOX, but it wasn't powered. And I think there's some pretty compelling preclinical data suggesting that cisplatin is a more potent DNA damaging agent relative to oxaliplatin. However, the counterpoint to the FOLFIRINOX regimen is that it also includes irinotecan, which is an important drug in this context as well. So I think there's pros and cons of both, and I always discuss both, but depending the person, their age, their comorbidities, and our goals of treatment, we might select one over the other.
So yeah, now that I think about it, in the ovarian studies, they had to be responding in order to get the olaparib. So, and do you know like what fraction of the patients in POLO actually responded?
Yeah, thank you. This is a good point. It was about half and half in terms of response and stable disease. The study did not require a partial response. So it's, we would get down to much smaller numbers of patients in that setting. And it's also, I think, fair to say, people were entering the study, there wasn't a RECIST comparison to baseline. So I think the response estimation is not perfect for POLO, relative to some other studies, and certainly relative to the cisplatin study, which was, independently verified and audited in terms of the response adjudication.
How important do you think it is to have I never kind of really thought about it, but now that you're bringing this up, it's really making me think about it a lot. I guess it's more theoretical, but when your vision of the way PARP inhibitors work, I mean, I always sort of thought like it was two separate things. You get the platinum, then you get, like an ovary, then you get the PARP, that they're separate. Do you think it's possible that in some way they're tied together? You really do need a response for a PARP inhibitor to work
I think so. I think
optimally?
I think all the cumulative data is very suggestive of this. And there was a very nice paper from Kim Rees-Binder and her team at UPenn recently that looked at the cohort of patients who were treated with rucaparib in the maintenance setting. So it was a parallel study to POLO, but non-randomized, where they collected ctDNA before and after, and they looked at the emergence of reversion mutations and other mechanisms of resistance. So a couple of things. If a person progressed on a PARP inhibitor, their chance of responding to platinum subsequently was much lower than people who didn't. Right, so if reversion mutation was present, and you can sort of take that more proximately, that isn't the only mechanism of resistance, and it may be a smaller frequency event relative to other mechanisms. But I do think we have a lot of learnings there about whom we should be thinking about using PARP inhibitors or other platinum agents in this population as we get into the routine ctDNA era in pancreas cancer, using that as an additional selection tool.
When you know that the patient's BRCA and you give the patient, for example, cisgem, do you get like more enthusiastic about adding the PARP as maintenance if they respond?
Yeah. I think it also depends on when you look, right? So we classically think of seeing response early in pancreas cancer. And on the cisplatin gemcitabine study, we had people reaching a partial response well beyond a year. So I think we sometimes underestimate the time it needs to fully identify response in this disease. And as we always kind of tell patients at the beginning, this disease is so biologically active, right? Some patients are so sick that, their disease is almost growing by the minute. I'm exaggerating a little bit to make a point. And that especially if they've had a scan, almost 4 weeks before they start, then they start at therapy. We do the scan at 2 months and we're seeing progression, but yet their pain is better. They've put on a couple of kilos, their CA99 is down, and you have this discordant signal. And that's a very common scenario, not just in the BRCA setting, but in pancreas cancer in general. So I'm always kind of swayed by the clinical scenario for that first decision point. I'm talking about outside of a trial when you have leeway, that we don't overcall progression early. Now, sometimes, of course, it is progression and it's very real and that's obvious, but it's not always clear on that first scan, and you get a better sense at the 4-month mark, and I would say even in this setting, probably the average time to response is closer to 6 months. But that's also the time point when we're starting to see resistance for some patients, and that's again a poor predictive marker for the value of PARP inhibitors if one is going to again integrate that as part of the treatment plan.
Just one more, maybe really naive question, but maybe you can help me understand it better. I always thought about you hear situations where people have BRCA germline mutations who have lung cancer and bladder cancer and whatever. And, you would imagine that there are people out there with BRCA germline mutations who smoke or whatever they do. And they just quote coincidentally get a cancer. Is there a difference in terms of response to PARP inhibitors? Like, if you sort of get what I'm getting at,
Right.
somebody who
Yeah.
gets it for a different, do they get it for a different reason? You see all these diagrams with the table with three things, etc. Like, from your point of view, how do you think about that?
Yeah, I think it's a very important question, right? So you're asking, is the tumor driven by BRCA? And in pancreas cancer, about 80% of tumors in the context of a germline BRCA are likely BRCA driven. We know that, and that's sort of not quite as high maybe as ovary cancer, but it's higher than breast and prostate. And the way that's important in practice is they're usually biallelic. So you have a somatic and a germline hit, you have two somatic hits, you have two germline hits, and that's the group that are enriched for benefit for platinum and PARP inhibitors. And maybe some of the diluted signal, right, and the lack of survival benefit that was seen in the Polo and the other studies, because they weren't able to address this, is that there weren't really tumors that were BRCA driven.
That's really interesting. How do you determine that? Like the usual germline testing pick that up?
So there's not a standardized test in pancreas cancer. The way we look at it is we look to see, do we see a second hit in the tumor, and look at that relative to the germline. But this can be complex. The other tools are looking at HRD detect or other HRD or RNA scores to look at measures of homologous repair deficiency. But again, none are validated for pancreas cancer, but HRD detect is probably, as good as it gets in this space, in this disease. It's not routinely used for practice just because there's a high proportion of patients who do have it de novo. But from the research perspective, as we try to, drill down and understand who's responding and who's not, and the reasons why and the mechanisms, this is critical. And this is, where we're really kind of focused now. And a couple of studies going to show will add more to our understanding in this space.
All right, please continue.
Thank you. Yeah, so building on the Polo, right, there's three trials that I think of, amongst others, that are highlighting important themes, and this is one of them. This is the SWOG study. It's in the maintenance space for patients with germline or somatic BRCA1 or BRCA2, and it's asking the question, does adding a PD-1 inhibitor to olaparib increase the depth of response, the duration of response? And we know from strategies in ovary cancer and some data in breast cancer that patients with germline BRCA alterations have higher levels of neoantigens, potentially more targets for the immune system. And there's a precedent for this. And this is a randomized study that will look at this with a PFS outcome. We have an in-house study here where we're also looking at this in a non-randomized fashion, looking at various levels of HRDness, those who have core homologous repair deficiency with germline or somatic BRCA1, BRCA2, or PALB2, those with other putated homologous repair genes alterations, and those who have an excellent response to platinum without any of those agents. So evaluating this question. And then the Apollo study is looking at moving a PARP inhibitor to the post-operative setting. This is a study led by the ECOG group, the Apollo trial, and Kim Rispinder and team. And this is for patients with pancreas cancer, including ACE&R, including squamous variants, who've completed all of their therapy for localized resected disease. So adjuvant, neoadjuvant, platinum, non-platinum, doesn't matter. As long as you're NED and have completed your treatment, you're eligible for participation here, and randomizing in a 2-to-1 fashion to olaparib versus placebo. This is an ongoing study, important one, and it gets the PARP inhibitor to the minimal residual disease space. And this may be the context where we'll see greatest value from this strategy in pancreas cancer, and it builds on the Olympia precedent established in the breast cancer world. So moving now to KRAS-directed therapy, where we are currently and where the future is going. And just to remind us of the importance of KRAS mutations in pancreas cancer, we see them in the vast majority of patients. And it's striking when you look at this graphically, pancreas cancer stands out relative to almost every other disease in terms of the frequency of KRAS alterations. And this is an individual, a 67-year-old who has advanced pancreas cancer, who received the 2 standard therapies, and then during her first-line treatment, genomic results became available and had a G12C mutation. I would say tolerated both standard treatments relatively poorly, probably at best had stable disease, but ultimately progression, and then had a year plus of disease control with remarkable quality of life. And this is, I think, what's so compelling when you see these biomarker contexts and aligned treatments and how patients love them relative to chemotherapy in terms of their quality of life. And the response wasn't maybe as striking as the clinical scenario was, but pain went away, literally put on 10 kilograms of weight and went back to work. And that's, sort of sticks out, right, relative to many of the things that we see. Ultimately had disease progression and now is, receiving further lines of RAS-directed therapy. And with that, we have this well-established precedent at this point in lung cancer targeting KRAS G12C. And this was amazing science from a decade ago now by Kevin Chokat and his colleagues, understanding the biology and physiology of RAS and targeting G12C and targeting it in the inactive state. And then as we move to the data specifically in pancreas cancer, we saw the sotorasib data updated and published earlier this year as part of the CodeBreak trial in the New England Journal of Medicine by Dr. Strickler and colleagues. And here, just speaking directly to the pancreas cohort, almost 40 patients enrolled and a median of 2 lines. You can see some had a lot of lines of therapy, just some maybe something different, perhaps not, about this patient population. And here, seeing a 20% response rate in the median of a 3rd-line setting with disease control of 4 months and survival of 7 months. And that, again, for single agent targeted therapy, provides proof of principle. And similarly, the adagrasib data extending a little further with a smaller cohort, very similar patient characteristics, median 2 to 3 lines of therapy, response rate of about a third, 33%, and a median OS of about 8 months. And these data were presented at an ASCO plenary and updated at the main meeting this year. And these data have been published, and based on the aggregate signal, the KRAS G12C inhibitors are listed now in the NCCN guidelines for pancreas cancer. So this is our own cohort here that we presented these data at ESMO, and about to, to hopefully see them in the future in print, just looking to see what are the characteristics in pancreas cancer of KRAS G12C individuals. So we had a cohort of 40 and some overlap with the Gini, the AACR Gini cohort. And you can see here median close to what we see, 67, slight preponderance of females, and notably a high percentage of current and former smokers. And this is higher than we see relative to an average patient with pancreas cancer. The oncoplot on the right looks to see if there's any differences in the co-mutation pattern. And we also looked at germline variants. And we noticed an enrichment of ARID1A and perhaps slightly higher skew in terms of germline predisposition genes. It's a small cohort, it's non-randomized, it's retrospective, so lots of caveats there and some data on outcomes to be presented. So this is, again, the excitement of where we are in 2023, just targeting the more common allele variants of KRAS in terms of D, V, and R, and the multiple strategies that are in the clinic. So targeting directly, targeting indirectly, targeting downstream, upstream with immunotherapy, combination vaccination approaches with other inhibitors of various levels on the pathway, and every aspect of this is being evaluated clinically now in pancreas cancer. And these are data that we presented at ASCO in a preliminary format, looking at a novel vaccine using a novel platform. This is a platform that's a lipid binding approach, where you can link in your antigen of choice. And here it was G12D or G12R peptide vaccine given via a subcutaneous injection to legs and arms on a priming phase, then a sort of period without dosing, and then a booster phase of vaccination for patients with pancreas and colorectal cancer who were NED, with the exception that they had rising biomarkers and or ctDNA positivity. And these were the outcomes. A little bit of a complicated slide, but just to kind of speak to the highlights. Firstly, a potent, specific T-cell immune response was generated against KRAS, both the known variant that the patient had, but also other KRAS variants, and that this seemed to be independent of typical present HLA restriction that's been observed for other KRAS presentation approaches, and that there was declines in biomarkers and both reduction and clearance in ctDNA, and particularly so at the highest dose levels, with the dose level here speaking to the immune adjuvant and not the vaccine itself. So this is continuing now with a broader spectrum of KRAS peptides, including the more common variants in pancreas, D, V, R, and then S and A, and several others, and with a goal to proceed to a randomized study in the adjuvant setting, hopefully next year. So more to come on this. And then lastly, just to highlight a few other biomarker-based approaches, but first to speak to the topic of KRAS wild-type setting in pancreas cancer. We said more likely to see this in younger patients. And in younger patients, we see the typical KRAS spectrum, but we also see a higher likelihood of having a germline alteration, similar to what's observed in average onset pancreas cancer, but just more likely. Not that this is necessarily explaining the increase in pancreas cancer we're seeing in younger people, particularly in younger women, but just keeping in mind the importance of germline and somatic profiling. And then when we look at this KRAS wild-type subset, there are three groups that we see. We see the fusions, and these are rare events, 0.2, 0.3, 0.4% of people with pancreas cancer, but RAF, ALK, NRG, RET, MET, NTRK, any fusion that's been seen in any other disease is described in pancreas cancer. We see alterations in the MAP kinase pathway, so we can see BRAF mutations, BRAF fusions here too, and we see increased rates of mismatch repair deficiency in this KRAS wild-type subset. So just the point being that it's important for every patient who's a candidate for therapy and for the family for germline testing, for every patient for somatic testing. But when you don't see a KRAS mutation and you do see other somatic alterations, you need to look closely at that individual's next generation sequencing, and you may need to do additional RNA testing to look for some of these fusions. Not all the panels identify them, but this is a very worthy group of elucidating. And so the importance of this was illustrated broadly from this notable trial from our colleagues from China, looking at this drug called nimatuzumab in the KRAS wild-type population. It's an EGFR inhibitor, which is selected because less rash and less diarrhea, combined with gemcitabine in locally advanced and metastatic pancreas cancer. So a few warts in terms of the study design, but doesn't matter. The key point is if you don't have a KRAS mutation and you add an anti-EGFR inhibitor, you do see a notable survival outcome with a hazard ratio of 0.5, suggesting again that this is a strategy of evaluation. And then speaking to some of these rare fusions, this is an example of a young man who was in his 30s, and he had come for probably a third opinion. He had been through 2 lines of therapy, and he had had several attempts to have a biopsy, which was unsuccessful. And we did an additional biopsy and identified no KRAS mutation, and then on reflex testing an NRG1 fusion. And he went on to receive targeted therapy with a HER3 inhibitor, monoclonal antibody. And again, as we see repeatedly with these targeted agents against these fusions, really excellent cancer control on single agents with a very favorable toxicity profile, with a deep response for an extended period of time in this disease. So just reminding us of the importance of thinking about these fusions and looking for them in the right clinical context. So couple of last kind of biomarker-directed approaches that are being evaluated in the clinic. As we've seen in gastric cancer, proof of principle of targeting Claudin 18.2 with the naked antibody zolbetuximab. This strategy is under development in pancreas cancer in a randomized phase 2, although likely to be a definitive study if it ultimately is positive. It's evaluating a biomarker-enriched group, 75% Claudin 18.2 expression, and then randomizing on a gemcitabine nab-paclitaxel backbone, a 2-to-1 ratio of adding the antibody versus a control of gemcitabine and nab-paclitaxel. So this study is well along, and hopefully it will have an answer, probably a little bit of time to go just yet. And if I can speak to a very interesting approach that's looking at a different vaccination strategy, a personalized neoantigen vaccine strategy in pancreas cancer. This is work led by Vinod Balachandran and our team here at MSK for patients with resected pancreas cancer who underwent resection, had their tumor after consent, had their tumor analyzed for neoantigens using several different platforms, and using an mRNA-based backbone and delivery system, personalized neoantigen vaccine was generated for these individuals, which contained up to 20 neoantigens. And then these vaccines were delivered following surgery and following a single dose of atezolizumab, and sequenced with FOLFIRINOX subsequent to the vaccines, and then one additional vaccination at the end. And the primary goals of the study were, can you do this? Is it feasible in a clinically relevant time? Can you generate an immune response? And that was adjudicated by ELISpot and T-cell expansion. And then secondarily, what's the outcome if you did have an immune response? So for the feasibility, yes, it was met. For the immune response, it was yes. About half the patients had an immune response, and you had to have both an ELISpot and a T-cell expansion assay positivity to qualify as a responder. And then the striking and the very encouraging part was that for the 50% of people who had an immune response at the time of initial analysis, in terms of relapse-free survival identification, there was a huge difference in outcome. And this is in a 16 patient study. So it's obviously not definitive in any way, but it proves that you can generate a personalized vaccine in pancreas cancer, you can generate a very potent immune response, and you can generate a clinical signal. And this has now led to a randomized phase 2 clinical trial that opened this past week, and for which we already have several patients enrolled in the it's in the setting of going to surgery, and so a surgery first approach in this context, and it's a one-to-one randomization of FOLFIRINOX plus personalized vaccines and atezolizumab compared to FOLFIRINOX in the adjuvant setting. So that's the trial design. And then lastly, just speaking about the other way that we may be able to begin to refine therapy selection for people with pancreas cancer, looks at transcriptomics or gene expression signatures in the advanced disease setting. And this data comes from the COMPASS study, which was a prospective trial conducted in Canada for patients receiving either FOLFIRINOX or gemcitabine and nab-paclitaxel. And then they underwent deep sequencing with a baseline biopsy. And this was not randomized, and then looking at outcomes. So about 80% of patients had this classical-like signature, about 20% had this basal-like phenotype. That was a more resistant phenotype, more on the squamous variants. And we saw that if you had a basal-like phenotype and you received FOLFIRINOX, you were much less likely to respond relative to patients who had the classical signature and received FOLFIRINOX. Sort of neutral for patients who received gemcitabine and nab-paclitaxel. And that's been translated into this study called the PAS-01 trial that's completing enrollment and is randomizing patients on a one-to-one basis to modified FOLFIRINOX versus gemcitabine nab-paclitaxel. That's not the most important part of it, but patients are having deep sequencing, both immune profiling, RNA sequencing, organoid generation, and looking at that as tools for treatment selection beyond, and looking at ctDNA and other biomarkers of response, including circulating tumor cells. And this study will provide insights into this. There's a unique molecular tumor board convened around this study, which is just an enormous learning experience and providing some opportunities for multiple questions to ask in this disease and insights in terms of future therapy. And it is designed to retrospectively validate whether using GATA6 as a biomarker of classical versus basal phenotype may be a way of selecting for a specific treatment approach in pancreas cancer. So more to come on this, not prime time yet in the clinic, and there are a few other studies that are looking at this and a few other signature tools being evaluated. So summing up where we are in 2023 with regard to biomarker-based treatments in pancreas cancer, we're really now, I think, firmly in the era of needing to profile patients from a germline and somatic perspective. KRAS targeted therapy, proof of principle with G12C in the advanced disease setting. We're now in the era of direct D and other common variants targeting of KRAS, looking at direct inhibitors, looking at immune-based therapeutics and other strategies. We've established the value of homologous repair deficiency and targeting in that space with platinums and PARP inhibitors in pancreas cancer, and looking at immune therapies and combination immune therapies in that context. And also not to leave behind here mismatch repair deficiency, about 1% of individuals with pancreas cancer where there's disease agnostic approvals for single and double checkpoint inhibition. But in the background all the time for all of these approaches and for standard therapy is the challenges of the tumor microenvironment, the challenges of tumor heterogeneity and resistance, and how we can solve this in pancreas cancer. Thank you.
So, wow. The reason I haven't asked you any questions is I've been holding my breath. There's so much of what you just went through I haven't heard about and have a lot of questions about. So the first thing I wanted to ask you about is one thing that I heard you say that I haven't heard before. I never know whether I'm the last person to realize this or everybody else doesn't know it. But, based on what you're talking about, it sounds like, do you think that most clinicians are looking at KRAS when they get a newly diagnosed pancreatic cancer patient? And do you?
So the answer is we definitely do. I don't think it's routinely happening yet, but I think we need to to make sure it happens. And, right now we're doing next generation sequencing, right? Just looking for things like mismatch repair deficiency, looking for the fusions, looking for the very occasional patient that will pick up with KRAS G12C. That's about 1%. But I hope very soon that we're going to need to know the DVR version of the disease that patients have, because there may be direct therapy alignment. And certainly for clinical trials, there are multiple D inhibitor trials in the clinic and more coming. And there are several pan-RAS or all-RAS inhibitors in the clinic. And there, maybe you can argue we don't need to know this, but we do, because we need to understand, what's happening downstream. We need to understand in terms of resistance, etc. So yes, I think genotyping patients at the KRAS level is going to be increasingly important. And right now, today, we have, guideline approvals for 12C for this in pancreas cancer.
Well, actually, what I was talking about is, I think oncologists are definitely looking for KRAS G12C, but what I'm talking about is looking for KRAS negative patients and looking at
Yes.
them differently and looking at, the message I got from you, which I never got before, was like, in a way, it sounds like there's almost two diseases there.
Exactly. Yes. So thank you for just highlighting that again. So yeah, it's equally important if you don't find a KRAS mutation, but there's a few caveats to that, right? And with tissue and pancreas cancer, with low cellularity relative to other diseases, you have to be careful how you interpret KRAS wild type. So if you don't see any somatic alterations at all, that almost certainly is not KRAS wild type. That's almost certainly a limitation of the tissue, maybe the assay, but much more likely the tissue, where the question becomes a compelling, or the observation becomes a compelling one. If you do have other somatic alterations and you see, for example, a P53 or an ARID1A mutation, and you don't see a KRAS mutation, right there you need to look at that closely. And that requires reflex testing to look for other things, and looking for these fusions, which are not always
Right.
readily detectable on DNA testing. You need RNA testing, you need Archer testing, or sometimes other orthogonal methods like IHC to validate whether or not there is a target like NTRK, etc., present.
So, and I assume that when you see these fusions, RET, et cetera, they respond the same way lung cancer does?
So this is where we get very excited in pancreas cancer therapeutics, right? We're always looking for these, and they're not common, but when we find them, they're real. Fusions, I think, have a very high actionability rate, and maybe even more so relative to things like BRCA, because the actionability, how do I want to say this? The actionability and the likelihood that we'll see a response is very high. The depth of those responses tends to be very real, and the durability of those responses tends to be significant in these settings. And I think anyone who looks after this disease, at any level of frequency, will have seen this and will be struck about how well these patients do for a year, 18 months, 2 months, and how, very gratifying it is for the patient and the family, and also for all the team, just to see the outcome and the difference that it can make for their health and well-being.
But from a clinical perspective, if it's, let's say, 10% of pancreatic cancer, which that's what you said, non-small cell lung cancer is only like 15 or 20%. It's not like everybody, all those patients have that. So from a clinical point of view, it sounds interesting. Now, you also listed HER2. Do you see responses to anti-HER therapy? What about TDXD?
Yeah, thank you. So maybe just want to go back to one of the points that you made. So yes, we quote 10% in KRAS wild type but it's actually less. And the harder you look, the more KRAS mutations you'll find. So the truly KRAS wild type is probably a lower frequency subset than we think about. So going to this, your question then about ERBB2 amplifications, mutations, what do we see? So we do see these in the KRAS wild type setting, again, as one of the, low frequency alterations. And in that context, I think it's real. We see a lot of overexpression on various NGS platforms that, to me, it's unclear when you have a RAS-driven tumor whether this is really meaningful or not. Now, our colleagues in the colorectal cancer world do describe instances where they think targeting this pathway in the presence of a KRAS mutation may have value. I'm certainly much less convinced in pancreas cancer, but it's about maybe 0.5% of people to 1%. But if we see in the KRAS wild type, then yes, I think it is likely real, and I think it is likely actionable, and I think trastuzumab deruxtecan is going to have value. To the group of people who don't have, a target for trastuzumab deruxtecan, we didn't see a lot of data in the recent ASCO. We didn't see a lot of signal in the recent ASCO presentation in pancreas cancer. It was a small number, and if I remember correctly, there were, I think, no responses, and even.
But I mean, that's all pancreatic cancer.
Yes.
They're not picking out your KRAS wild type patients.
No. Unselected. Cool. Yeah.
Another question I was also fascinated, general oncologists always think about other tumors, even though people don't always think about that. And I was also fascinated by this idea that EGFR antibodies are helpful in these KRAS negative patients. Of course, in a way, that's kind of like in colon cancer, we have that thought. Is the data strong enough that you would ever consider using an EGFR antibody outside a clinical trial if you had a patient like that?
I think the answer is yes, and it comes from historical data in the unselected world. So there were two studies that were done that are of interest, right? The Alatinib trial in 2005. Yeah, remember that, right? And
but again, that was in everybody, right?
It was in everybody. There was a small subset had tumors, and there was a retrospective analysis of this in the KRAS wild type. The hazard ratio pretty strongly favored erlotinib in that retrospective analysis.
Yeah, so cool.
Yeah, and then Philip
is really fascinating.
Did a study with, on the basis of high levels of EGFR expression in pancreas cancer, and there is very high levels of EGFR expression, looking at cetuximab. Didn't see a signal in the overall population, but I'm betting there wasn't enough samples to my knowledge at the time, but I'm betting in retrospect if there was, we would have seen the same thing. So it is considered, an option to use either an EGFR TKI or a monoclonal antibody in the KRAS wild type setting. And there's even discussion about whether or not, based on the Chinese study, that we should do a study here in North America to answer this question with the newer generation agents.
Incidentally, does the NCCN guidelines talk about the KRAS wild type subset?
Yeah, it does. It mentions that, but it's still pretty limited because it's all small numbers, but it does speak to fusions, and it does speak to, for example, BRAF mutated pancreas cancer, which you see in the KRAS wild type subsetting and
right.
And dabrafenib and trametinib combination being FDA approved in that setting. Yeah.
A couple other questions I just sort of jotted down when you were talking about the adjuvant PARP trial. I was just flashing on. You know what % of patients go for resection of all newly diagnosed pancreatic patients?
So about 10 to 15% of 100 patients diagnosed with this disease will have resectable disease, and then maybe another 10 to 20% of patients with borderline and locally advanced disease will go on to an opportunity for resection.
Another question, you were talking about zolbetuximab, about what fraction of patients with pancreatic are positive for Claudin 18.2?
Yeah, so it's a great question, right? And it depends where you draw your threshold, and it depends on what population you're looking at. I think right now, using the high threshold, which is 75%, in the metastatic disease setting, it's about 25 to 30% of people, and that's a very enriched subgroup in terms of the degree of claudin expression. And it's a question of whether, if this works, we'll need that high a level. And perhaps as we get into the era of ADCs and bispecifics, that this will become less important in terms of the degree of expression. So I think a moving target.
So one more question. I don't know if you know Georgina Long, who's a melanoma investigator from Australia, but they reported we're doing a program with her, and she was part of this group that reported on this wild study that I saw at ASCO. I'm like, where did this come from? Which it was in melanoma, adjuvant setting. They use IO adjuvantly, so it was Pembro plus or minus an mRNA vaccine that was individualized for neoantigens. I'm like, whoa, where did that come from?
Yeah, so I think it's mRNA is a great vaccine delivery system, and that's what it is. It's a delivery platform for the neoantigens. I think the customization is all about the neoantigens. It's not about the mRNA. That's it's a soluble, suitable for suitable for subcutaneous administration. I think we're hoping to go to intravenous administration going forward to get around some of the limitations of the immune response generation that may come from the delivery approach.
So, you do, that's another thing I didn't understand is how it's individualized. So you actually do like an NGS on the patient's tumor?
Yeah.
And
So
what do you look for?
Yeah, so DNA and RNA sequencing, and you look for neoantigens using a number of algorithms, and this is increasingly be refined. It started with version 1. I think we're now on version 3, and seeing the most potent neoantigens. And I think what we were surprised in the pancreas study is these were not the classic driver oncogenic mutations like KRAS and P53, etc. They were other things that we conceive of as passenger mutations. And I think we still have a huge amount to learn about what these neoantigens are, whether these are shared across people. We didn't see that in the small sample size that we looked at in the original study, but that will be evaluated more definitively in the randomized phase 2.
So these are somatic mutations, basically?
Correct. Somatic mutations, not for the most part driver neoantigens. And we talked about the other strategy that's underway that is actually targeting driver neoantigens using a different platform delivery system with peptide vaccines. And both of these I think are hugely interesting. One is immediately scalable, it's off the shelf, it's non-customized, whereas the personalized is exactly that. It's going to need to most likely be personalized based on an individual's tumor. And the observation for this, right, came from work looking at short and long-term survivors. And those that were long-term survivors in pancreas cancer had about 12 times more T cells in their tumor relative to those that were short-term survivors. And the idea came from there, okay, if you have T cells, maybe you can generate a vaccine to expand and amplify these T cells. And that was the whole basis behind the study.
Well, it's still going over my head, but maybe if I keep asking people, I'll eventually figure it out. But it sounds really fascinating. One other thing I was just going to ask you about, you mentioned at one point something about younger women having higher, I forgot what it was, the higher incidence
of pancreas cancer. Yeah, so the epidemiologic trends that are being observed in pancreas
Right.
cancer are similar to what are being seen in other GI malignancies, that we're seeing this trend of younger people being diagnosed, with colorectal, right, with esophagogastric, with pancreas cancer. And the question is, why, what's behind that. And it's not all about germline genetics. It's clearly not. It's not all about diabetes. It's not all about smoking. But one of the observational trends is that even though pancreas cancer still remains, most common in people at the age of 70 and older, that where we're seeing the biggest change is in younger women. And I think a lot of putative explanations, whether there's some diet considerations, some lifestyle, whether there's hormonal interplay, whether there's antibiotics, whether there's environmental exposures. I don't think anybody really knows, but lots of hypotheses looking at this question across the GI space in terms of changing epidemiology.
And in terms of the increase that's been seen in younger people, is the magnitude of that similar with pancreas and upper GI as it is with colon? Because I think I hear it talked about more with colon.
Yeah, no, I think it's fair to say just colon is a much more common disease. It's more common there, but the trends are happening. I think we've just recently, in the last few years, been able to describe that and publish that. Not we, but the field, specifically in pancreas cancer, and it's still, relatively speaking, a small percentage of the overall incidence of the disease.
When you look at the, again, colon and upper GI, do you see more women, younger women?
It's a good question. I am not aware of that, and it looks to be real in pancreas cancer, but it isn't a huge number of observations that observation has been drawn upon. So probably have to be a little careful on my part about not overstating that observation. But I don't think there's a sex differential observed in colon and rectal cancer, right, and esophagogastric. But I'll ask the gurus next door and my office in front of me here.
No, that's why it struck me when you mentioned that, because I haven't heard it in the others. Any thoughts about why? I mean, obviously, maybe something hormonal, but the other thing I was thinking about is, I guess, to some extent, pancreas to me is a little bit smoking related, whereas the other two aren't. Maybe more women are smoking. Any hypotheses about what's going on?
Yeah, so I think it's clear that smoking counts for probably about a quarter of the overall incidence of pancreas cancer. It's absolutely a smoking-driven disease, but not by exclusivity and by any means. I think it's also clear that doesn't appear to be the major driving factor in this changing epidemiology in younger people. It's probably part of the story. And it's also interesting, right, in the KRAS allele variants discussion we had related to 12C. So we know that occurs more commonly in smokers. We're certainly not seeing more 12C that we know about in younger people, as best the magnitude of the cohorts indicate. It's part of it, I'm sure. And I'm sure it's not going to be one thing, right? It's going to be the interplay of multiple, probably epidemiologic, lifestyle, and other factors here.
It's always a pleasure to work with you, Eileen. I learned a lot today, and I'm really not shocked, but really had my eyes open a lot. I wonder what Zev's going to say about this, because, oncologists are always looking for rare things. They're used to it now. It started with lung cancer, where they would find these mutations that occur in 1%, and then whatever, they have phase 3 trials, et cetera. But what you were saying about the non-KRAS is really interesting. Even if it's 5%, that's not too small for people to think about, I don't think.
No, absolutely. And if you just want to simplify the message, right? A younger individual with a KRAS wild type and with a mucinous, that may be a characteristic as well. But right there, that's a group to focus on. And by younger, I'm thinking, 55 or younger. Having said that, we have seen a couple of these fusions in people in their late 50s. So we probably even need to be more conservative in terms of our upper age bar, and maybe think about 60 in the world of youngness today.
One more thing I was going to ask you about. Any thoughts about Nalirifox? And
I'm sure that's...
how is it? I guess you probably have a few, but how has it affected globally the way you think about? I mean, not so much new research, new trials, but clinical care today. How do you
Yeah, so
see
I think
it?
that trial answers a very important question, right? It addresses in black and white that a quadruplet combination is better than gemcitabine and paclitaxel. So to me, for patients who are fit and absenting any other biomarker context, it's FOLFIRINOX or potentially NALIRIFOX. We're not yet in the FDA approval space. Potentially coming, as you know, and hopefully we'll see this in press shortly. That will likely raise further awareness. I do think that people will use it, and it's met a benchmark of a threshold. Always the question in people's mind: is it better? Is it different? Is it safer? Is it less toxic than FOLFIRINOX? And we obviously don't have data to address any of that directly. I hoping that people will choose to look at this in uh, trials and see. I think using the modified version of oxaliplatin is nice. That helps with the neuropathy and probably allows us to give this a little longer, and that may be part of the tolerability and part of the efficacy aspect of NALIRIFOX.
I'm just kind of curious, going beyond the data in terms of your personal experience and just the way you think about it. Or I don't know how many patients you've treated with Nalirifox, but I'm curious. Do you think in general it's a better tolerated or easier regimen or less toxic regimen than FOLFIRINOX the way it's currently being given?
Relative to FOLFIRINOX at full dose, which I personally never give. I think unquestionably it's more tolerable relative to modified FOLFIRINOX. That's probably the question for today, right? Because I think not everybody, but most people now have accepted, based on the adjuvant data and based on the devimistat negative trial, that modified FOLFIRINOX is equivalent, and there's pooled and meta-analysis done also speaking to this. So to me, that's the full dosing is just adding toxicity that we don't need. For modified FOLFIRINOX versus NALIRIFOX, I think choices are good. There's the issue of expense and the issue of regulatory approval yet to be met. And for, I think, many countries in the world, this will not be an option. I think it's something we'd like to see explored and evaluated to understand whether it's something that we should be building off and whether we should be using it as the reference for regulatory approval. And I think all of those discussions are underway and will be teased out over the next, year or two.